Okay. So I'll go quickly. Oh boy, or not, because my packs have been a little bit funky today. So this was a young, like not a young, middle-aged patient from outside hospital, and we actually did know the diagnosis at the time of study, but you can see that this patient has the dreaded double duck sign. Um, you can see that the pancreatic duct is uh, dilated up to region of the neck, and so is the hepatic duct. When we look at the post contrast, again, you can see biliary dilatation all the way to the level of this kind of hypovascular area in the neck. So, for the fourth years, when you see something like this, number one through 100 is pancreatic. Oh, that I don't know what that is. It's pancreatic cancer until proven otherwise. But we had a study, old study on this patient, and you can see that this is 3 years ago. You can see 3 years ago, patient had a study, and you can see that his pancreatic duct was very dilated right here, and his common duct was even more dilated. So this is not something that's new to this patient. You can see here, everything is dilated again to the same exact level, although we don't quite see as much of a mass-like effect as now. So, pancreatic cancers don't tend to hang out for 3 years without doing anything. So that kind of goes out of the window. So anybody has any thoughts, or should I just continue?
Is it IgG4?
Right. So you pretty yes. So this is
DDX.
yeah. So this is autoimmune pancreatitis, also known as IgG4-related pancreatitis. And I found this handy dandy article. Hold on, just have to pull it
Do
up.
they know that in the initial imaging?
So I actually don't. This is an outside study. We only got it. We got the follow up. We already knew
Yeah.
what was happening. Okay, so
Yeah.
here we go. I don't know why I can't bring up. Oh, here we go. Autoimmune pancreatitis mimicking pancreatic cancer. So I found this cute little study that was granted only small number of patients, but if you just look at the abstract, you can see patients with focal autoimmune pancreatitis quite commonly present with symptoms which are worsened for pancreatic cancer, and they have imaging features quite often that mimic the pancreatic cancer as well. So it may be a hard diagnosis. However, if you do EUS and fine needle aspiration, you actually get the correct diagnosis quite often. So I don't know what I assume that they biopsied it. We tend to biopsy all pancreatic suspicious pancreatic masses under EUS. And again, in vast majority of cases, with this appearance, it's going to be just adenocarcinoma. But this patient got quite lucky. Okay. Anyway.
Prospectively, I don't know if I would include IgG.
Oh no. I don't. No, there's nothing you can. Even that paper basically. The only way to tell them apart is cytology. So,
Yeah.
but the point that we're making is that you should not jump into, let's say, Whipple for the
Whipple, yeah.
without doing like a EUS cytology.
Yeah.
And again, in majority of patients, this would have been just a cancer.
Yeah, it's kind of a diagnosis of exclusion, but sometimes if they have like several negative biopsies, they're kind of, but haven't clinched the IgG4, they'll do a steroid trial, see if it responds. Although occasionally,
hi, Artie.
Which I guess could be frustrating.
occasionally the like a pancreatic cancer can also respond to steroids, but sometimes they'll try that. And then occasionally they actually go to Whipple even with like if they don't have the biopsy, and then a small percentage of those will come back with benign disease. So.
Sorry, last one was